Welcome to This Week in Neurosurgery. This week, we're covering 10 notable papers spanning cerebrovascular risk prediction and hemorrhage management, skull base and neuro-oncology decision-making, and spine, pain, and functional neurosurgery. Let's dive in. We start with the cerebrovascular papers, where the common thread is deciding how aggressively to investigate and treat lesions whose natural history is uncertain. In the Journal of Neurosurgery, a group building on two prospective multicenter cohorts developed and externally validated a nomogram for 5-year symptomatic hemorrhage risk in sporadic cerebral cavernous malformations. Across 331 training patients and 57 external validation patients, 5 factors carried independent weight: prior hemorrhage, lesion size above 1.5 centimeters, an associated developmental venous anomaly, brainstem location, and Zabramski type 1 appearance. Brainstem location was the single heaviest driver, associated with roughly a 4-fold higher hazard, with type 1 lesions and lesions over 1.5 centimeters, each associated with roughly a 3-fold increase. The model discriminated well, with a concordance index of 0.81 in training and 0.87 in external validation, and the authors were able to separate a genuinely high-risk stratum from a low-risk one. For the clinic, this is a tool for the conversation rather than a mandate for surgery. A patient with a small, non-brainstem, previously silent cavernoma sits in a very different risk tier from one with a large hemorrhagic brainstem lesion, and now you can show them that difference. The external cohort is small, so treat the calibration as promising rather than settled. Staying with hemorrhage, Neurosurgery published a retrospective single-institution cohort of 202 patients with initial catheter angiogram-negative subarachnoid hemorrhage that pushes back on the idea that this is a uniformly benign condition. Cluster analysis separated non-cisternal, perimesencephalic, and diffuse bleeding patterns. Delayed cerebral ischemia was rare overall, occurring in 3 patients, about 1.5%, and only in the perimesencephalic and diffuse groups. But nearly 11% developed hydrocephalus, requiring temporary cerebrospinal fluid diversion, and 2.5% went on to a permanent shunt. The diagnostic yield of repeat angiography beyond the index study was just under 4%, and essentially every positive repeat study was in a patient with diffuse blood, with one exception involving focal cortical blood. Meanwhile, 7 patients had a complication from repeat angiography, and 2 of those suffered a permanent neurological deficit from periprocedural stroke. Magnetic resonance imaging and magnetic resonance angiography of the brain found no missed vascular lesion in anyone. The practical message is a bleeding pattern-driven protocol. Repeat angiography for diffuse or focal cortical patterns, where the yield justifies the stroke risk, and restraint in classic perimesencephalic bleeds, while still watching those patients for hydrocephalus rather than discharging them as low risk. The Journal of Neurosurgery also published the largest series to date of Cognard type 5 dural arteriovenous fistulas, drawn from the multinational Condor registry across 16 academic centers. Only 37 of 1,077 fistula patients, about 3%, had perimedullary venous drainage. Most presented with non-hemorrhagic neurological deficits, and the foramen magnum was the commonest location. Embolization was the primary treatment in 2/3, achieving complete obliteration in 71%. Upfront microsurgery, used in about 1/5, obliterated 88%, while radiosurgery succeeded in only 40%. Complications were low, transient in 3 patients and permanent in 1, and at a mean of about 2.5 years, roughly 7 in 10 patients had a modified Rankin score of 2 or better, with no deaths. Notably, the MRS declines that did occur were attributed to causes other than the fistula. This supports aggressive but tailored multimodal treatment, and it argues against radiosurgery as a primary strategy for these lesions. Rounding out the vascular theme, World Neurosurgery reported on 180 consecutive patients with primary middle cerebral artery M2 occlusion treated with thrombectomy, comparing contact aspiration first with stent retriever first. Procedure-related subarachnoid hemorrhage, defined broadly to include asymptomatic minor blood on 24-hour CT, occurred in 29% overall, and was more than twice as common with a stent retriever first approach, 39% versus 18%. Smaller vessel diameter, more device passes, and the stent retriever first strategy were each independently associated with hemorrhage, and the finding held across several sensitivity analyses. Importantly, reperfusion success and functional outcomes were similar between strategies, and the hemorrhage itself was not independently associated with worse outcome once complexity and baseline severity were accounted for. So this is a safety signal rather than an efficacy signal. Reasonable grounds to favor aspiration first in small caliber M2 branches without expecting a change in 90-day function. Turning to skull base and neuro-oncology, 3 papers address how much intervention is enough. An international study across 27 institutions published in the Journal of Neurosurgery examined single-fraction stereotactic radiosurgery for vestibular schwannoma in 309 octogenarians. Tumor control reached about 95% at both 3 and 5 years, with progression-free survival of 71% at 5 years and overall survival of 78%. The competing risk analysis is the number to remember. By 5 years, only about 5% of patients had tumor progression, while nearly 20% had died without progression. Communicating hydrocephalus developed in 4% and was managed with cerebrospinal fluid diversion. Age, sex, tumor volume, Coos grade, and margin dose did not predict survival or progression. In other words, radiosurgery reliably controls the tumor in this age group, and competing mortality, not the schwannoma, dominates the outlook, which should temper how aggressively we treat small, asymptomatic lesions in very elderly patients. Also in the Journal of Neurosurgery, a contemporary series of 67 facial nerve schwannoma surgeries in 61 patients tested a function-centered strategy: nerve-preserving subtotal removal with bony decompression for moderate palsy, and total removal with reconstruction for severe or complete palsy, guided by intraoperative electromyography and a 5-category location-based classification. Nerve preservation was chosen in about 70% of cases and left facial function improved or stable in 87% of those. Mean House-Brackman grade improved from 3.5 to 3.0 with preservation and from 4.6 to 4.0 with reconstruction. Overall, function improved in about half of cases and worsened in 13%. The trade-off is durability. Over a mean follow-up of just over 7 years, more than a quarter of the preservation group needed additional treatment. Tumors confined to the temporal bone, younger patients, and favorable electromyography responses did best. Neurosurgery contributes a pragmatic answer to a recurring ward question: do preoperative steroids sabotage the biopsy in suspected primary central nervous system lymphoma? In 50 histologically confirmed cases over a decade, 34 had received steroids before biopsy. Only 1 patient in the steroid group required repeat biopsy, and none in the non-steroid group did, with no statistically significant differences between groups. The single non-diagnostic case involved prolonged steroid exposure. The reasonable reading is that a short course of steroids for symptomatic mass effect is unlikely to cost you the diagnosis, while prolonged exposure, particularly in patients who could have a steroid-responsive inflammatory mimic, remains a genuine hazard. This is a small retrospective series, so it argues for pragmatism rather than complacency. Get the tissue promptly and sample adequately. Finally, spine, pain, and functional neurosurgery. In the Journal of Neurosurgery, Spine, a series of 114 patients with severe degenerative sagittal imbalance treated with anterior column realignment reported acute proximal junctional failure in nearly a third of patients within 6 months. With revision surgery in 14 patients, about 39% of failures and 12% of the whole cohort at a mean of about 5 months. Bony failure drove the great majority of revisions. Independent risk factors were a cranially directed screw angle at the upper instrumented vertebra, which carried by far the largest effect, greater preoperative thoracic kyphosis, and a larger postoperative proximal junctional angle. The actionable point is technical. Screw trajectory at the upper instrumented vertebra is modifiable in the operating room, and in patients with substantial preoperative thoracic kyphosis, it deserves particular attention. On the perioperative side, the Journal of Clinical Neuroscience published a network meta-analysis of 13 randomized trials in 879 adults undergoing instrumented spinal fusion, comparing ketamine and pregabalin as opioid-sparing adjuncts. Against pregabalin 150 milligrams as reference, ketamine was associated with significantly lower opioid consumption in the first 24 hours, a difference of about 57 milligrams of morphine equivalents, while pregabalin 300 milligrams in control did not differ significantly from the reference. For 24-hour pain scores, only control differed, with modestly higher pain than pregabalin 150. Adverse events were infrequent and similar across arms. But only 6 trials contributed opioid data, and these are indirect comparisons with wide confidence intervals, so this is hypothesis-generating support for ketamine within an enhanced recovery protocol, not proof of superiority. And in the Journal of Neurosurgery Pediatrics, the Child DBS Registry reports on 12 children under 7 years old, below the age threshold of the FDA Humanitarian Device Exemption, who underwent palatal deep brain stimulation for dystonia across 5 North American centers. Half had prior intensive care admissions for status dystonicus, and nearly 2/3 of the operations were urgent. The Burke-Von-Marsden movement subscale fell by about 40% at 6 months, and the benefit persisted at a year. Complications were not trivial. 3 children had stereotactic pin transgression beyond the inner table, and 4 required surgical management of wound complications, though no child suffered neurological sequelae and infected hardware was successfully reimplanted. 3 children died of their underlying conditions more than 6 months after surgery. The signal is that stimulation works in very young children with severe refractory dystonia at the cost of higher surgical risk, relevant to both referral practice and the regulatory conversation. If you only have time for one paper this week, make it the neurosurgery study of catheter angiogram-negative subarachnoid hemorrhage. It directly reshapes a common admission pathway, telling you which bleeding patterns justify repeat angiography and its real stroke risk, and reminding you that these patients still develop hydrocephalus. Here are the key takeaways from this week in neurosurgery. First, angiogram-negative subarachnoid hemorrhage is not uniformly benign. Repeat angiography earns its keep in diffuse or focal cortical bleeding patterns, and hydrocephalus occurs in about 1 in 10. Second, for cavernous malformations, brainstem location, prior hemorrhage, size, an associated venous anomaly, and Zabramski type 1 define a genuinely high-risk group worth quantifying with the validated nomogram. Third, in M2 thrombectomy, a stent retriever-first strategy roughly doubled procedure-related subarachnoid hemorrhage without any difference in reperfusion or functional outcome. Fourth, in octogenarians with vestibular schwannoma, radiosurgery controls the tumor in about 95%, but competing mortality far exceeds progression. Treat the patient, not just the scan. Fifth, in adult deformity surgery using anterior column realignment, upper instrumented vertebra screw trajectory is the dominant modifiable predictor of revision for proximal junctional failure. And finally, a short course of preoperative steroids is unlikely to compromise lymphoma diagnosis, but prolonged exposure still can. That's your roundup for this week in neurosurgery. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you've been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one, in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.